Hello, students. So now we'll be talking about the maxillary division of cranial nerve 5, also known as V2, V for the Roman numeral 5, and 2 because it is the second division of the trigeminal nerve, also known as the maxillary nerve. So what should we know about this nerve? It's sensory only, and it's sensory for the maxillary teeth, bone, periodontium, and associated soft tissues. So that means like gingiva, periodontal ligament, sometimes the pulp of the teeth. It also innervates the mucous membranes of our sinus, our maxillary sinus, and our nasopharynx, our hard and soft palate, the skin of our lower eyelid, upper lip and side of nose, that's the ala of the nose, and part of the tonsillar area. So here we can see some branches of the maxillary nerve that we'll be talking about at length throughout this PowerPoint. The zygomaticotemporal, the zygomaticofacial, the posterior superior alveolar, and this one right here, that's a big one, and getting patients numb. The nasopalatine, which is right here, coming out of that incisive foramen, again, an area that we'll be getting numb. The greater palatine, we use that too, we'll be getting patients numb there. The lesser palatine, we try to avoid that area so the back of the throat doesn't get numb. The middle superior here and the anterior superior alveolar branches are here, and then they are the middle superior here, and then the anterior superior have branched off from the infraorbital, which comes out right here. So the MSA, middle superior alveolar, and the ASA, anterior superior alveolar, are branches of our IO, or infraorbital nerve. So the maxillary nerve leaves through the foramen rotundum, and then it enters the pterygopalatine fossa, where it divides into its main branches. So let's take a closer look at that pterygopalatine fossa, which here we've kind of cut it away. Here's the ganglion here, maxillary nerve, and the pterygopalatine ganglion is right down here. So here's the fossa. It's kind of hidden deep. So let's orient ourselves. So this is the right side of the skull. This is the first molar, second molar, third molar of wisdom tooth. This is the maxillary bone here. Our lateral pterygoid plate right here, which is a part of our sphenoid bone. It's where our lateral pterygoid muscle originates. Here is our maxillary tuberosity. You can feel that sort of bony protuberance behind the last molar in the maxillary arch. And then sort of superior up this way, we have a fissure, and then inside here is a pterygopalatine fossa. We have the maxillary nerve after it's gone through the foramen rotundum of the sphenoid bone. It has a pit stop here in the pterygopalatine fossa. And so we have pterygopalatine branches of V2. And these pterygopalatine nerves attach at the pterygopalatine ganglion in the pterygopalatine fossa. And that ganglion serves as sort of a relay station, branches parasympathetic fibers of the facial nerve, also sort of synapse in this ganglion, and the pterygopalatine branches of the maxillary nerve also synapse in this ganglion. And the ganglion is nothing more than a collection of cell bodies outside of the brain, parts of the neurons. And so on the other side of the pterygopalatine ganglion, we have 5 branches of the maxillary nerve. We have the lateral nasal, which is the mucosa of the nasal cavity. We have the nasopalatine. We have the greater palatine, the lesser palatine, and the pharyngeal. So here I want you to underline nasopalatine and greater palatine because these are important for us to know where these nerves exit and soft tissue landmarks, because we will be using these nerves, we'll be anesthetizing these nerves so that we can work on certain areas of the mouth. And this is just a diagram showing the 5 branches of those pterygopalatine branches that have branched off our maxillary nerve. Our lateral nasal, right here, our nasopalatine here, our greater palatine here, our lesser palatine here, and I don't believe it shows the pharyngeal branch. So let's talk a little bit about the nasopalatine nerve, also known as the NP. So it enters the nasal cavity, so it leaves the pterygopalatine fossa and then enters the nasal cavity through the sphenopalatine foramen. And everything I'm saying here is written down exactly in a couple of slides. So you don't have to be sort of copying it very quickly because I do have it written down. So let's take a look here. Oh, I see that nasopalatine fossa, nasopalatine nerve right here. It enters the nasal cavity through that sphenopalatine foramen, crosses the roof of the nasal cavity, travels along the septum, and then the floor of the nasal cavity. Then now here, so that last image, sort of a lateral view of the nasopalatine branch, sort of coming through the nasal cavity down, and then finally it actually exits or passes through the incisive canal and enters the oral cavity through the incisive foramen. So this is the nasopalatine nerve here, exiting out of this foramen. Nasopalatine nerve, incisive foramen, covered by the incisive papilla, which we burn sometimes when we have hot pizza. We can't wait to eat the piece of pizza, so we bite into it and the cheese sticks there and burns. We call it the roof of our mouth. We've actually burned the incisive papilla. And there are right and left branches that come out of here. To me, this kind of looks like cat whiskers. Whenever I see it, that's what it looks like to me. And what does this innervate, this nasopalatine nerve? It innervates the lingual bone here, the mucous membranes, and the gingiva of the premaxilla. And the premaxilla is basically canine to canine. So it doesn't do much with innervating the teeth, but the bone here and the tissues that are here from canine to canine on the palate, on the lingual surface, will get numb if we inject the patient right here. Occasionally, rarely, but sometimes this nasopalatine nerve also innervates the central incisors. So let's look. Okay, enters the nasal cavity through the sphenopalatine foramen, crosses the roof of the nasal cavity, travels along the septum, then the floor of the nasal cavity, passes through the incisive canal and enters the oral cavity through the incisive foramen. So it's entering the oral cavity through the incisive foramen. So the nerve itself is sort of exiting out to the tissue. So it enters the oral cavity by way of exiting the incisive foramen. And that's important because when a nerve exits a foramen, such as the nasopalatine, it usually means that it just gets like soft tissue and maybe some bone numb, but it doesn't get the pulp and the teeth numb. So the right and left nasopalatine nerves enter through the same opening, kind of giving it that cat whisker look, and it innervates the lingual bone, mucous membranes, and gingiva of the premaxilla. And here is what it looks like when we're actually injecting the area, when we're getting the patient numb. So We use the cotton-tipped applicator with a little bit of topical anesthetic, which is that jelly. Some of you may have had an experience with that at the dental office, where they kind of swab on something onto the soft tissue that numbs it first. And then we will approach the incisive papilla at this sort of 45-degree angle. So our soft tissue landmark for the nasopalatine injection is the incisive papilla, actually sort of the chubbiest portion of the incisive papilla. The incisive papilla on a lot of people looks like a teardrop. So we look for the chubbiest portion of that. So we just did nasopalatine. Next we'll do the greater palatine. And the greater palatine is right here. Greater palatine foramen, greater palatine nerve. So this descends through this pterygopalatine canal right here. And then it enters the oral cavity through the greater palatine foramen. So it enters the oral cavity by exiting the greater palatine foramen. So if we look on this image here, this shadowed area shows sort of what gets numb when you've given a greater palatine injection. And this right back here is your greater palatine foramen. And the greater palatine nerve will exit out of this foramen, and it innervates the palatal mucosa in bone from the premolars back, as well as lingual gingiva on one side. So if we look here, here's our greater palatine foramen. Here's our other greater palatine foramen. So you only get half. The anesthesia will extend, or the innervation will extend to about the midline of the palate here, up to the premolar, back to the third molar, the soft tissue, and the lingual bone. That's what the greater palatine anesthetizes or innervates. It also communicates with terminal branches of the nasopalatine nerve. So what does that mean? Well, here we see our incisive foramen. And so if the nasopalatine nerve comes out of this incisive foramen, it will go from, because we have a right and a left branch that come out of the same foramen. So it will innervate from canine to canine. But right about this point here, where we have canine and then first premolar, occasionally the greater palatine nerves that extend forward and the nasopalatine nerves that extend backward will kind of communicate with each other. So what does that mean? That means that if the patient needs to get numb here, you anticipate that they will be numb up to the first premolar, this lingual gingiva right here. It's just killing the patient. And so you give them a greater palatine injection thinking, well, that's where the greater palatine innervates. And if I numb this nerve right here, I will get this lingual gingiva numb. But the nasopalatine nerve, because it kind of extends backward, right, you may have some innervation in this spot, right? They kind of cross over or cross innervate the same spot. And so because that happens, you may also have to give the patient a nasopalatine. They may still say, oh, it's still really bothering me. So there's some cross innervation from a separate nerve. So greater palatine nerve, in summary, it descends through that pterygopalatine canal. It enters the oral cavity through the greater palatine foramen. It innervates the palatal mucosa in bone from premolars back, as well as the lingual gingiva on one side. It's either the right side or the left side. It will only go to the middle of the palate. And it can communicate with the terminal branches of the nasopalatine nerve. And here we can see how the injection works, how we get the syringe back towards the greater palatine foramen to get that greater palatine nerve that's exiting that foramen and entering the oral cavity. It's about 3 to 4 millimeters in front of the posterior border of the hard palate, and it's usually just distal. It's usually just behind the second molar. And it runs between the mucoperiosteum and the osseous hard palate. So if you can almost think, I kind of think of the palate as a box, and where someone's torus would be the top of the box, and then two 90-degree angles where the teeth are. And this is sort of right in between. We look here, if this is the top of the box, and then we go down, it goes up, across, and down. That's what the palate, in my mind, I think about. So when it says it runs between the mucoperiosteum and the osseous hard palate, it means it's basically at that line. Here's the hard palate going straight across, and then this is where the teeth are going down. It's right at that junction, right behind the second molar usually. So that is our greater palatine nerve. Now our lesser palatine nerve, not so super important to us. It exits through the lesser palatine foramen, and it runs in a posterior direction. So whereas the greater palatine exits the greater palatine foramen and comes forward towards the nasopalatine nerve, the lesser palatine nerve exits and goes back. It runs in a posterior direction, and it innervates the soft palate and palatine tonsils. So the lesser palatine foramen is posterior to the greater palatine foramen. Can you get this numb? You could. I mean, if you're way far back, you would have to be very, very posterior. And if you're behind the greater palatine foramen and you get the lesser palatine nerve exiting out of the lesser palatine foramen, then the person, half of their throat will feel numb. It's uncomfortable for the patient. It's not very likely to happen either, but that is something that is a possibility, but unlikely. And then we have the pharyngeal nerve, and this is just a small nerve that supplies the nasal part of the pharynx. So here are some other branches. So we did the pterygopalatine branches of V2, and then we'll do the zygomatic branches, which include the zygomaticofacial and zygomaticotemporal. We'll talk about the posterior superior alveolar, the infraorbital, the middle superior alveolar, the anterior superior alveolar, and their terminal branches. So let's look at the zygomatic nerve. So it leaves the maxillary division in the pterygopalatine fossa. And the zygomaticofacial nerve, they both travel in an anterior direction. And it travels, the zygomaticofacial travels through a foramen of the same name, and it supplies the skin of the cheek. That kind of makes sense to me. Like, I'm thinking face, the zygoma is our cheekbone. So cheek, face, it supplies the skin, the sensory sensation to the skin of our cheek. The zygomaticotemporal travels also through a foramen of the same name, which is located in a small suture that exists between the sphenoid bone and the zygoma. And the zygomaticotemporal supplies skin on the forehead, as well as some of the secretory cells of our lacrimal gland. But zygomaticotemporal zygoma makes me kind of think of cheek and my temple, and so it's the skin on the side of the forehead, that sensory sensation up there. And both of these enter the eye orbit through the inferior orbital fissure, which is located just underneath the superior orbital fissure. These aren't too important to dentistry or to anesthetizing teeth. So posterior superior alveolar nerve. Those are a lot of words. Posterior, okay, so it's behind. Superior, think of that. That means maxilla. Alveola means bone. And nerve. Usually known as PSA for the posterior superior alveolar. So the posterior superior alveolar, or the PSA nerve, here it is. Here it is right here. It travels along the infratemporal surface of the maxilla. So the infratemporal surface, it kind of comes behind. If we think here is the maxillary tuberosity, this looks like that lateral wing here. And our infratemporal surface right here. Now, it enters the maxilla. It enters the maxillary bone through PSA foramina. Now, you notice I didn't say foramen here. I said foramina. So there's actually multiple little openings here that the PSA nerve enters into the maxilla. Sometimes the PSA has two trunks and one of them will remain external to the bone and one will enter the bone. But there's usually about 3 or 4 foramina that the nerve will enter in. And so it's called the PSA foramina, located right here. And what does the PSA nerve innervate? The posterior of the maxillary sinus. And it also innervates the pulp, the buccal bone, buccal gingiva, and periodontal ligament of the maxillary molars, except for the mesiobuccal root of the maxillary first molar. So that's what it innervates. This is what gives sensation to the pulps of our third molar, our second molar, and our distal buccal of our first molar. The pulp, the buccal bone, buccal gingiva, and periodontal ligament. So this is a big one. This one is important to us. We use the PSA injection a lot to get these areas numb for patients for comfort. So PSA travels along the infratemporal surface of the maxilla. It may have two trunks. One will remain external. It will enter the maxilla through the PSA foramina. So it's entering the bone. That means, and it's innervating the pulps of those teeth. So that's going to get a good pulpal anesthesia of the teeth. So it's entering the foramen, which means it gets the teeth. If it exits a foramen, it usually means it's soft tissue. So what does it innervate? The maxillary sinus, posterior, and also the pulp, buccal bone, buccal gingiva, and periodontal ligament of the maxillary molars, except for the mesiobuccal root of the maxillary first molar. And here it is showing it. You can see how it has, like, it's branching off. It's entering those multiple foramina located on that infratemporal portion of the maxilla. And this is what it looks like. To try to get it numb, you have to go way far back, about to the distal buccal root of the second molar. And we have to get the needle here very close to where the PSA nerve enters that PSA foramina. So behind the maxillary tuberosity that's located here, this bony landmark. So one of our soft tissue landmarks here is the distal buccal gingiva of the second molar and the height of the mucobuccal fold. So that's our PSA. The next one we're going to talk about is our IO, or infraorbital nerve. So infra, below, orbit, eye. So it's below the eye. And let's look here. Hey, this is the infraorbital foramen, and look at the nerve. It's coming out right below our eye. So that kind of makes sense, right? So this is a terminal branch of the maxillary nerve. It enters the orbit through the inferior orbital fissure and follows the infraorbital groove to enter the infraorbital canal. So within that canal, within this canal, the nerve itself splits. The IO will split into the MSA, and it will split into the ASA, and here are the terminal branches of the IO that comes out here. So within the IO, or infraorbital canal, two branches split off, the MSA and the ASA. So if we have posterior superior alveolar, MSA will be middle superior alveolar, and ASA will be anterior superior alveolar. So with the IO, what does the IO innervate? Well, it innervates the pulp, buccal gingiva, buccal bone, and periodontal ligaments of the central lateral canine, first premolar, second premolar, and the mesial buccal root of the first molar. And all this bone and tissue and pulp and PDLs on one side, because don't forget, I wanted to stress that too, the PSA is also on one side because we have a right PSA and we have a left PSA. We have a right IO and we have a left IO. So the IO nerve innervates all of these teeth, their PDLs, the buccal bone, the buccal gingiva, on one side. So here this would be a right IO. This is our infraorbital foramen right here. And this is a summation of the IO, terminal branch of the maxillary nerve. That means terminal kind of means the end. So it ends when it exits out of the infraorbital foramen, right under our eye. It will enter the orbit through the infraorbital fissure, and it follows that infraorbital groove to enter the infraorbital canal. And then once the nerve is in the canal, it separates or branches off for an ASA and an MSA nerve, and then it finally terminates at the infraorbital foramen. So this is what the injection looks like, an IO injection. We want to numb, you saw how many teeth get numb from this one injection. So the penetration site, the soft tissue that we're going to be looking for is over the first premolar intraorally, the height of the mucobuccal fold directly over the first premolar. The other thing that we want to look for is the infraorbital foramen. So what you do, and what I can ask you to do right now, is take your index finger and kind of feel around right underneath your eyeball, right? If you feel the kind of the rim of your orbit, you may feel like a little notched out area. You should be able to feel it. It should be sort of directly underneath your pupil. If you feel that little notch and you come down about the width of your finger, you'll be right around the infraorbital foramen. It's about a finger width below the infraorbital notch. It's about 10 millimeters below. So that's where we're aiming for when we use an infraorbital injection. We're aiming to get all the way up to the infraorbital foramen, where the infraorbital nerve exits. Now let's look at one of the branches of the IO, the middle superior alveolar nerve. And here it is. And it descends through the lateral wall of the maxillary sinus. And what does it innervate? The middle of the maxillary sinus, in the pulp, buccal bone, buccal gingiva of the maxillary premolars, and the mesial buccal root of the maxillary first molar. Now, the MSA nerve is only present in about 28% of the population. if the patient does not have an MSA, and 72% do not have an MSA, the anterior superior alveolar injection will cover the premolars, and the PSA will anesthetize the mesial buccal root of the first molar. Therefore, you give an MSA injection, you will get the premolars, not the mesial buccal of the first molar. So again, this is on one side, so this is our right side. And if you're in the 28% of the population that have a middle superior alveolar nerve, then what gets numb on this right-hand side? The mesial buccal root of number 3, and the pulp, and the buccal bone, and the buccal gingiva, and the PDL that innervate on this mesial buccal surface, the whole thing of number 4, and the whole thing of number 5. Pulp, buccal bone, buccal gingiva of those maxillary premolars. Okay, and this is just a summation of our MSA nerve. So it descends to that lateral wall of the maxillary sinus. It innervates the middle of the maxillary sinus, the pulp, buccal bone, buccal gingiva of maxillary premolars, and mesial buccal root of maxillary first molar. And it's present in 28% of the population, and this is on both sides. So you would have to give a right MSA to get the right-sided maxillary premolars, or a left MSA to get the left side maxillary premolars. So what is our soft tissue landmark when we're giving anesthesia? It's the mucobuccal fold directly above the second premolar, the maxillary second premolar. All right, anterior superior alveolar nerve. See right here. It descends to the anterior wall of the maxillary sinus. Let's see what it innervates, right? Which of the following, okay, so right here, what is it innervating? That ASA. So we're on the right-hand side of the patient. We've done a right ASA. The right anterior superior alveolar nerve innervates the canine, lateral, and central on one side. So this would be a right ASA. You'd have to do a left ASA to get 9, 10, and 11. So it's pulp, buccal bone, buccal gingiva, and PDLs of the canine, lateral, and central on one side. Now this, just like how we talked about the nasopalatine and the greater palatine having some crossover, the ASA, the right ASA, and the left ASA have some crossover right here at the midpoint. So occasionally, if you've anesthetized this area, this nerve, right about here, the patient will say, oh, I feel that. It's because the left-sided ASA is communicating or crossing over a little bit with the right-sided ASA. And so occasionally, you'll have to do a left-sided ASA to get this mesial portion of tooth number 8. So ASA descends to the anterior wall of the maxillary sinus, innervates the anterior of the maxillary sinus, and the pulp, buccal bone, buccal gingiva of maxillary anteriors on one side. So here's what the injection looks like. Our landmark is just medial to the canine eminence. That's sort of that canine protrusion that you can see. You can feel a little bit, it's a bony protrusion where the canine is. We go just medial to that. That's our soft tissue landmark for an ASA injection. And then finally, terminal branches of the infraorbital nerve. So the infraorbital nerve exits to the infraorbital foramen, and it divides into 3 terminal branches. The inferior palpebral, which is the skin of our lower eyelid, the external nasal, which is the skin on the side of the nose and the ala of the nose. The superior labial is the skin and mucosa of the upper lip. So, when you give an infraorbital injection, you probably saw how high you had to go to get up to that foramen. And if you have the infraorbital nerve anesthetized, the clue to you that you got it, that you were high enough, is the patient will say their lower eyelid is numb. If their lower eyelid, if this terminal branch of the infraorbital nerve, the inferior palpebral, gets it, then you have gone deep enough and the infraorbital nerve has been anesthetized, and you'll get that big chunk of teeth and pulp and bone from the centrals all the way back to the mesiobuccal root of the first molar. So the eyelid is a big indicator that the infraorbital nerve injection has been successful. So here is kind of a little diagram. We just talked about the maxillary right now, the maxillary nerve, and it shows you this is what the anterior superior alveolar gets. This is the middle superior, the posterior superior alveolar, greater palatine, and nasopalatine. And you can see this is on one side. It's not both sides. So if I look at this, this is the left side. So this would be left ASA, left MSA, left PSA, left GP. The only problem or mistake is the nasopalatine. Even though there is a right and a left branch, they both exit out of the same foramen, that incisive foramen that's right here. And if you go underneath that incisive papilla with anesthesia, both the right and left sides will usually become anesthetized if you're deep enough. So even though there are right and left branches, you usually get both of them when you do this injection. And it's really the only one that happens. All other injections, you have to enter the right side for the right ASA and the left side for the left ASA. And this is a summary here that you can take some time and look at of the maxillary nerve, or the maxillary division of the trigeminal nerve. So just a quick review. It's a sensory nerve, right? It allows us, right? We feel like, oh, you have pain in your teeth. If you're drilling into someone's tooth, they're going to feel pain in their pulp. That's going to send pain messages to the brain. They're going to sense pain. The maxillary nerve leaves the skull through the foramen rotundum, which is located on the sphenoid bone. And it includes sensations for the upper teeth, the nose, the palate, the mouth, the cheek, and the temporal or the temple region. And this is also just a quick cheat sheet for you. What innervates, what nerve innervates which teeth, which pulp, areas of the maxilla. So you can take a look at this. And that concludes V2.